Welcome to the deep dive. Today, we're embarking on a really crucial journey. We're looking into a system that, well, keeps us alive, but is constantly under siege, our respiratory tract.
That's right.
And for you, as future medical professionals, getting a handle on infections here is, it's absolutely foundational.
Absolutely.
Our mission today is simple. Give you a solid understanding of the structures, the surprising defenses, and the common and sometimes pretty scary infections that can mess with breathing. Think of it like your essential toolkit.
Exactly. And we've designed this deep dive to be super practical. We want to equip you with insights so you understand not just what these infections are, but critically, why they show up the way they do.
Right.
We'll connect the dots, look for patterns, and basically make the complex stuff, make sense as you start thinking about management.
Okay, let's start with the layout, the architecture. Our respiratory system, it's kind of like a two-story building, isn't it?
That's a great analogy.
You've got the bustling entrance hall, the upper respiratory tract, or URT, and then the really critical inner sanctum, the lower respiratory tract, the LRT. What really defines these two areas? Why is that split important?
It's a really useful distinction. The URT, that upper part, is like the body's initial processing unit for air. Think of it as an air traffic controller, its main job. Filter, heat, and humidify the air coming in.
Okay.
So that includes your nose, nasal cavities, sinuses, pharynx, uvula, tonsils. Each plays a part. Nose hairs trap big stuff. Tonsils act like immune checkpoints.
Got it. Preparing the air.
Exactly. Preparing the air, first line of defense. Then the lower respiratory tract, the LRT, that's where the real magic happens, the actual gas exchange. Oxygen in, CO2 out. And because it's so delicate down there, its defenses are, well, quite remarkable.
So if the URT is the main entrance, like you said, it must have some pretty serious security, right, to handle the constant barrage of microbes.
Oh, absolutely. A crucial point. Yeah. Both tracts have strong defenses, but the URT being right there on the front line is especially well armed.
Okay, like,
Well, beyond the physical things like hairs and mucus, you got these tiny cilia. They're like microscopic brooms constantly sweeping unwanted stuff away. But it goes deeper. We have specialized antimicrobial peptides. Think of them as the body's own built-in antibiotic arsenal.
Ah,
Yeah, things like defensins, they defend against lots of microbes. Lactoferrin, that limits bacterial growth by grabbing onto iron. And lysozyme, it actually breaks down bacterial cell walls.
wow.
You can remember them as the DLL squad: defend, limit, lyse. It's pretty cool. Plus, there's the whole mucosal immune system, and importantly, our normal resident microbes, our microbiota, they form a protective shield too.
Okay, this is where it gets really interesting, I think, and maybe a bit counterintuitive, like not all germs are bad.
Exactly. That's a huge shift in how we think about it.
So what does our URT normally host, and how do these good guys actually help us out? It's not just taking up space, is it?
No, not at all. It's a crucial distinction. We used to think the body was sterile until, invaded, but now we know the URT is this vibrant, bustling ecosystem home to bacteria, viruses, fungi.
Really?
Oh, yeah. Loads of the Staphylococcus species, Corynebacterium, Dolosigranulum, Moraxella. In the nose, you find Haemophilus, Legionella. Even things like Staph aureus or Strep pneumo can just hang out in the pharynx without causing trouble sometimes.
Huh.
And these friends with benefits, they're not just sitting there. They actively stop pathogens from setting up shop. They compete for food, basically starve out the invaders. And they even release substances that inhibit the growth of the bad guys.
So they're like microscopic guard dogs, not just competing, but actively fighting off intruders.
That's a great way to put it. They produce their own microbial deterrents. It's a very dynamic relationship.
Okay, so given all these impressive defenses, the cilia, the peptides, these helpful guard dogs, you'd think we'd be invincible. But here's a question for you listening. What do you think is a really common, everyday infection that still manages to sneak past all that security and cause symptoms in the URT? Think viral. Think something almost everyone gets.
That's a good one to ponder. And the answer, of course, is that nagging, sniffly, just plain annoying thing. The cold.
Right, of course.
It's mostly caused by viruses, and rhinoviruses are the main culprits usually. And they're clever. They attach to specific ICAM1 receptors on your nasal lining cells.
Yeah.
That attachment is the key. It kicks off viral replication, which leads to cell damage. The cilia stop working properly, and you get this release of inflammatory chemicals. And that's why you get the sneezing, the runny nose, the congestion.
Makes sense.
And here's a neat little anchor for recall. Rhinoviruses actually prefer cooler temperatures. around 33 degrees C, which is roughly the temperature inside your nasal cavity.
Oh, interesting.
Yeah. And that preference helps explain why colds usually stay put in the URT. They don't often travel down into the warmer, lower respiratory tract. It's like a natural temperature boundary, keeping them contained.
That temperature thing is fascinating, so they like the cooler front porch.
Okay, let's shift gears. Put this into practice. Imagine you're in clinic. A 26-year-old woman comes in. She's had 10 days of nasal congestion, thick yellowy-green discharge, pressure-like pain over her cheeks and forehead. Gets worse when she leans forward. What's high on your list?
Okay, classic presentation. That really points towards sinusitis, inflammation of the sinuses. And it almost always involves the nasal cavity too, so we often call it rhinosinusitis.
Right.
Now, most cases, they're viral, but a smaller number can be bacterial, often things like strep pyogenes or Haemophilus influenza. The key mechanism is that inflammation and mucus block the sinus drainage. Creates that awful pressure cooker feeling.
Okay, so what's the key clinical pearl there for bacterial involvement? The big one to watch for is something called double sickening. That's when the patient starts to feel a bit better, and then, boom, they suddenly get worse again after a few days. That's your clue.
Ah, double sickening. That's a good one to remember. So, keeping that in mind, how do you usually manage sinusitis? Especially if you suspect bacteria.
Well, management is usually about symptom relief first. Decongestants, pain relief. We only really think about antibiotics if the symptoms drag on for more than 10 days, or if they're really severe, or if the patient is immunocompromised. And that double sickening clue helps you decide when it might be time for antibiotics.
Got it. Okay, let's pivot to something much more urgent. A real airway emergency potential. Imagine a 6-year-old boy rushes into the ED. Sudden fever, sore throat, trouble breathing. He's sitting bolt upright, leaning forward, drooling. Voice is muffled. It sounds bad.
It sounds very bad. That's an absolute emergency.
What's the first thing you do? The absolute priority.
This scenario screams epiglottitis. Inflammation of the epiglottis, the little flap covering the windpipe and the structures around it. The absolute non-negotiable priority, before you even confirm anything else, is securing the airway.
Right, immediately.
Immediately. In kids, that often means intubation, because that swelling can happen incredibly fast and just close off the airway. Historically, Haemophilus influenza type B, or Hib, was the common cause in kids. But thankfully, the Hib vaccine has dramatically reduced that. It's a huge public health success story. Now, we see other bacteria more often, like strep pneumonia, sometimes viruses or fungi.
So how do you confirm it once the airway is safe?
Well, you might do a laryngoscopy to directly see the swollen, cherry red epiglottis. And a lateral neck x-ray can sometimes show the classic thumbprint sign. The swollen epiglottis looks like the pad of a thumb. It's a really memorable visual.
The thumbprint sign. Wow, okay. And then antibiotics after securing the airway?
Yes, appropriate antibiotics once the airway is safe and sound.
Okay, another concerning case, especially for the little ones, a 4-month-old baby. 2 weeks of worsening cough, really severe coughing fits, followed by this high-pitched whoop sound when they gasp for air, sometimes vomiting afterwards. Baby looks exhausted, not feeding well. What causes that distinctive cough?
That unmistakable whoop. That is the hallmark of pertussis, or whooping cough. It's caused by a bacterium, Bordetella pertussis. It's a gram-negative coccobacillus.
And why is it so dangerous for infants?
It's incredibly dangerous because their airways are just so small. Those intense, prolonged coughing fits can stop them from breathing altogether, causing apnea, cyanosis, even brain damage from lack of oxygen. It's terrifying.
Yeah.
The disease usually goes through stages. First, the catarrhal stage, looks like a regular cold. Then the really rough paroxysmal stage with those awful coughing fits, the whoop, maybe vomiting. And finally, the convalescent stage, a slow recovery.
How do you diagnose and manage it?
Diagnosis is typically with a nasopharyngeal swab for culture or PCR. Management involves antibiotics, usually macrolides like azithromycin, mainly to shorten the time they're contagious and reduce spread. Plus isolation, of course. But the absolute key takeaway, it's largely preventable with routine childhood vaccinations. Vaccination is critical.
Absolutely critical. Okay, we've talked a lot about the URT defenses, but what about down below? In the lower respiratory tract, the LRT, where the really delicate gas exchange happens, how does the body protect that even more vulnerable area?
Great question. The LRT has its own sophisticated defenses, building on some URT mechanisms, that ciliary escalator we mentioned, even more vital down there. It's constantly sweeping mucus and trapped particles upwards from the tracheobronchioles towards the throat to be swallowed, like an internal conveyor belt clearing debris.
Okay.
And then, deep in the alveoli, the tiny air sacs, you have specialized immune cells called alveolar macrophages. Think of them as the alveolar SWAT team.
Huh, I like that.
Yeah. They patrol the air sacs, engulfing and destroying any pathogens that manage to get that far down. And of course, you also have IgA antibodies in the mucus providing targeted immune defense.
An impressive internal security force. Now, we talked about the URT having that diverse microbiome, the good guys. Given these strong LRT defenses, what would you predict about the microbial environment down there? Is it packed with microbes like the URT, or is it different? Take a second to think about that, listeners. So what's the verdict? Is the LRT a microbial metropolis or more like a quiet, clean room?
Well, it's a subtle but really important point. For a long, long time, the medical world thought the LRT was completely sterile. No microbes at all.
Right, I remember hearing that.
Exactly. But we now know, through more advanced techniques, that it does contain microorganisms, just at much, much lower levels than the URT. The diversity is also lower.
So not sterile, but very low numbers.
Precisely. And that finding actually highlights just how effective those LRT defenses, the escalator, the macrophages, the IgA, really are. They do an amazing job keeping the microbial load way down.
Okay, so that debunks an old myth. Good to know. Now let's shift to a really major player in respiratory infections, a huge cause of illness and death worldwide, pneumonia.
Yes, absolutely.
Let's paint a picture. 65-year-old man comes in with 3 days of fever, a cough-producing yellow sputum, shortness of breath, also has sharp chest pain when he breathes in. History of smoking, type 2 diabetes, what are we thinking?
That clinical picture, especially with the risk factors like age, smoking, diabetes, is classic for pneumonia. It's an inflammation in the lung where fluid fills up the alveoli and bronchioles, messing up gas exchange.
And the immediate concern is?
The immediate concern is how sick he is and the potential for rapid decline, given his background. Symptoms like the productive cough, fever, shortness of breath, pleuritic chest pain, that pain with breathing are typical. On exam, you might hear crackles, find decreased breath sounds over the affected area.
It sounds serious.
It is. Pneumonia is common and can be very serious, leading to lots of hospital admissions and, unfortunately, significant mortality, especially in vulnerable populations.
Now, pneumonia isn't just one thing, is it? How do doctors start to categorize it? I know there's something about where the patient got it.
That's a really crucial first step.
Yeah.
Categorizing by where it was acquired helps predict the likely bugs and guides initial treatment.
Right.
So we have community-acquired pneumonia, CAP.
Okay.
That's pneumonia picked up out in the community, not in a healthcare setting.
Yeah.
Often follows a viral infection like the flu. The usual suspects are generally less resistant.
Makes sense. And the other type?
The other main type is hospital-acquired pneumonia, HAP,
Yeah.
sometimes called nosocomial pneumonia. This develops 48 hours or more after someone's been admitted to the hospital.
Ah, okay. Different environment, different bugs.
Exactly. HAP is often more serious. Hospital patients might be weaker, their defense is down, and the bacteria lurking in hospitals can be nastier, more resistant to antibiotics. A specific subtype is ventilator-associated pneumonia, VAP, for patients on breathing machines, which has its own set of challenges.
That CKT versus HAP distinction seems vital for treatment choices. Now, within CKP, I've heard about typical versus atypical bacteria. What's that all about?
Another key distinction, mainly for antibiotic choice. Typical bacteria are the ones we can usually grow on standard lab cultures and see with a gram stain. They're often sensitive to common antibiotics like beta-lactams.
Right.
The number one cause of bacterial CKP is Streptococcus pneumonia, or pneumococcus, gram-positive coccus. And critically, it has this protective outer capsule. Think of it like a slimy, slippery shield that makes it really hard for our immune cells to grab onto and clear. That capsule is a major virulence factor.
Ah, that explains why it's so common.
Right. Other typicals include Staph aureus, Haemophilus influenza, Klebsiella pneumonia. Then you have the atypicals.
Okay, what makes them atypical?
They don't show up well in gram stain, they're harder to culture, and they're naturally resistant to those beta-lactam antibiotics, so you need different drugs. Examples include Legionella pneumophilia, Mycoplasma pneumonia, and chlamydia pneumonia.
Got it. Typicals versus atypicals impacts antibiotic choice. So with pneumonia, how does it progress? And how do clinicians figure out how sick someone is?
Well, for lobar pneumonia, the kind affecting a whole lobe, there's a classic pathological progression, often remembered by the anchor CRGR. Congestion in the first day or two, then red hepatization, the lung looks like liver for a few days, then gray hepatization as cells break down, and finally, resolution over weeks. CR.
TMRGR, okay. And for assessing severity, deciding who needs hospital admission.
Assessing severity is absolutely critical. We use clinical judgment, bedside observations, blood tests, definitely a chest x-ray to see the pattern. Is it lobar, patchy bronchopneumonia, or interstitial? And microbiology tests try to pinpoint the bug. But for a quick, practical assessment of severity, especially for CAP, the CURB-65 score is invaluable.
CURB-65. Okay, break that down.
It's a simple point score based on 5 factors. Confusion, new onset. Urea level in the blood, BUN 7 millimolar. Respiratory rate 30 breaths per minute. Blood pressure low. Systolic 90 OR, diastolic is 60. Blood pressure low, age 65.
1 point for each.
Yep, 1 point for each. A score of 0 or 1 usually suggests outpatient home-based care is okay. Score of 2 generally means hospital admission, 3 or more. That patient is high risk, definitely needs the hospital, and you should consider ICU assessment.
Wow, that's super practical. CURB-65.
It really helps guide those crucial early decisions. Treatment usually starts with antibiotics, like amoxicillin for typicals, maybe adding a macrolide if you suspect atypicals. For HAP, remember the timing matters. Early HAP, less than 5 days in, might still be strep pneumo, but late onset HAP after 5 days. You worry more about resistant bugs like MRSA or Pseudomonas. Need broader antibiotics.
Right, the hospital bugs. Okay, let's move to another major global challenge, TB. Consider this. 32-year-old man, 3 weeks of cough, night sweats, low-grade fever, losing weight. Cough is now bringing up sputum, sometimes streaked with blood, recently immigrated from Indonesia. What should leap to mind?
That whole picture, the chronic cough, night sweats, weight loss, fever, especially the Haemophilus, bloody sputum, and the history from an endemic region screams tuberculosis. TB. Mycobacterium tuberculosis, a bacterium with a really unique characteristic. Its cell wall is full of mycolic acids, these waxy lipids. This makes it acid-fast.
Acid-fast, meaning?
Meaning it resists being decolorized by acid alcohol after being stained. We use a special stain, the Thiel-Nielsen stain, to see it under the microscope. It appears bright red or pink against a blue background. That acid fastness is a key diagnostic feature.
And that waxy wall probably makes it tough to kill.
Extremely tough. It protects the bacterium from drying out, from disinfectants, from many antibiotics, and even from our own immune system defenses. It's also why it grows so slowly.
So the symptoms are often gradual?
Yes, often insidious. That chronic cough, lasting more than 2, usually 3 weeks, is key. Plus the systemic stuff. Weight loss, night sweats, fatigue, fever. Haemophilus is a later, more worrying sign. Risk factors are things like exposure, living in endemic areas, and anything that weakens the immune system like HIV.
And treatment, I hear it's long.
It is long and complex because of that tough bug. Standard treatment involves multiple antibiotics taken for an extended period, usually at least 6 months. The core drugs are typically rifampicin, isoniazid, pyrazinamide, and ethambutol, often called RIPE.
Yeah.
Adherence is crucial. There is a vaccine, the BCG, but its effectiveness varies a lot.
RIPE for TB. Got it. Okay, we've hit bacteria hard. What about viruses in the LRT, beyond the common cold moving down?
Oh, viruses are huge players in LRT infections too, and sometimes the effects go way beyond the lungs. 3 big ones to keep in mind. First, influenza.
Flu.
Right. An enveloped RNA virus. Infects URT and LRT. Its envelope has 2 key proteins, hemagglutinin, H, that's its attachment anchor to get into our cells, and neuraminidase, that helps the new viruses exit the cell to spread. That's where names like H1N1 come from.
H1N, anchor, and exit.
Clinically, compared to a cold, flu usually hits harder systemically. High fever, really bad fatigue, muscle aches, myalgia. Much more than just a runny nose. Management is often supportive, but antivirals like oseltamivir, a neuraminidase inhibitor, are important for high-risk folks, and flu shots are key prevention.
Absolutely. Okay, virus number 2, one we know all too well recently.
Indeed. COVID-19, caused by SARS-CoV-2, another enveloped RNA virus. It uses the ACE2 receptor to get into cells, causes both URT and LRT disease, and as we know, it led to a devastating global pandemic. A stark reminder of novel respiratory viruses.
Definitely. And a third virus, maybe one people underestimate.
Yes, measles, another enveloped RNA virus. People think of the rash, maybe the initial cold-like symptoms and conjunctivitis, but the complications can be severe, including serious pneumonia, which can be fatal, especially in malnourished kids or the immunocompromised. Also encephalitis, blindness, severe diarrhea. It really highlights the critical importance of the MMR vaccine.
Wow. Measles pneumonia is serious.
Very. And stepping back, understanding all these different bugs is vital, but so is understanding how they spread. Most respiratory infections travel via airborne particles, droplets from coughs and sneezes. That's why things like masks, Ventilation, hand hygiene, basic public health measures are so fundamentally important.
What an incredible journey through the respiratory battlefield, from those microscopic defenses in the upper airway, the cilia and peptides, to the big guns like alveolar macrophages down below, and then all those different invaders, rhinoviruses, strep pneumo, TB, influenza.
Hmm,
We've covered a ton.
we really have.
Hopefully, for everyone listening, you now feel you've got a much more solid, practical foundation for tackling these conditions when you see them.
I hope so too. We've seen how the body protects itself and how cleverly pathogens find ways around those defenses. Remembering those key patterns and anchors, the double sickening in sinusitis, the thumbprint sign in epiglottitis, the importance of S. pneumos capsule, the usefulness of CURB65, that's the stuff that will stick with you and really help in clinical practice.
Definitely.
And maybe one final thought to leave you with. As you learned today, our respiratory system is this amazing defense network, but it's under constant pressure from a changing world. So consider this. How might things like ongoing climate change, more global travel, the worrying rise of antibiotic resistance, how might these huge trends reshape the landscape of respiratory infections you'll face in your career, both the familiar ones and brand new emerging threats? It's a dynamic field, always evolving, something to keep thinking about.